I'm your regular anchor. Today we're going to be looking at knobology, labeling and image orientation in ultrasound. But before we begin, I want to acknowledge these wonderful people who have contributed greatly to my knowledge. Now, knobology or instrumentation. It is beyond the scope of this discussion to look at the technical aspects of scanning in details, but knobology will be shown during hands-on training sessions, especially with those training with me. However, this section briefly will discuss some of the most frequently used functions of ultrasound machine. It is recommended that you learn the different capabilities of the equipment that is available to you, which may vary from machine to machine, so that you can be able to optimize the image quality and diagnosis. So the first we're going to look at is the keyboard. The keyboard has various capabilities as provided by the manufacturer. Some keyboards are monofunctional, others are multifunctional. So depending on what the manufacturer put in there, the functions will be highlighted in the user manual. The next will be, by the way, keyboard does what a keyboard would do. It's universal, but some keys has many functions. So the next is the time gain compensation. Now it is used to amplify all the received attenuated echoes or signal. Now the attenuation caused by depth of the reflector is what is being amplified, not by reflecting tissue properties. This correction makes equally echogenic tissue look the same, even if they are located in different depths. It is also known that the emitted ultrasound wave gets smaller as it penetrates tissue. It is a phenomenon that is called attenuation. So one might expect later echoes from deeper layers to have smaller amplitude than the superficial echoes, even if those layers have the same echogenicity. So that's what the help of TGC will do to make all of them from the same organ look the same. So if the ultrasound image was formed directly by a raw returning echo, image will appear brighter in superficial layer and darker in deeper layer. But TGC is used to overcome these appearance, this artifact. Then there is the near and far gains. Now these controls are used to equalize the differences in echoes received from various depths as they display on the screen. So when compensating for sound attenuation, the near to far control, usually they appear as these sliding ports. They should be gradually increased as you scan. So this image shows you the effect of the near and far gain and how you can use it to balance out the image. So here in the image, you have anterior part of the liver is much brighter with darker posterior part in the image, which is expected because because of attenuation. But after you have corrected the TGC, both the anterior and the posterior part is showing similar brightness of medium level of echogenicity in the liver parenchyma. So we have a abdominal sagittal image of the liver. There you see the TGC with proper overall gain setting. Now the TGC and overall gain setting affects the image quality of the liver. the homogeneous liver with mid-level echo is demonstrated in this case. Note the intensity of the echo is the same in the anterior, in the mid, and the posterior region of the liver. Why? Because for proper use of the TGC and the overall gain. Now, what about the overall gain proper? Now, it is used to amplify all the received echoes or signals equally, irrespective of the depth they are coming from. So when you turn your gain, it applies to all the echo equally. So if there is an echo that is brighter than the other, that same brightness will be amplified equally, but not like TGC where it blends the echo to be the same. Now they don't become the same, they only increase equally with overall gain. Depth. This control is used to adjust the size of the image so that organs and adjacent structures or region of interest are equally visualized. One of the keys you want to be playing around with, especially where you are looking at a particular lesion or area of interest. Now there is a focal point. It is a control that has one or more toggle buttons. Now this allows the operator to choose the level at which the ultrasound beam is focused to increase the resolution at a specific point or points where there are several focal zones. Now this control should be set at most posterior aspect of the organ or the structure that is being imaged. So failure to properly adjust the gain control, or you did it poorly, the focal point during scanning may result in suboptimal quality and misdiagnosis. But most importantly, remember to place your focal point below on the posterior aspect of the organ of interest. More importantly, don't forget that point. Doppler systems are used to evaluate blood flow in large vessels such as the aorta and small vessels such as the renal artery, testicular artery, superior mesenteric artery. Frequently used Doppler systems include color Doppler, pulse wave spectral Doppler, continuous wave spectral Doppler, and power Doppler. So now the following that I'm going to mention are some of the examples of how Doppler can help in diagnosis of pathology. Doppler can help to distinguish type of flow in arterial, venous, or mix. You can distinguish ovarian or testicular torsion from inflammatory conditions. Can establish presence or absence of blood flow. Can establish direction of flow to determine whether there is a reverse of flow, such as portal hypertension. You can evaluate intensity of flow, such as demonstrating the increased vascularity in some inflammatory conditions or malignant tumor. Can calculate the velocity of flow, such as evaluating for renal stenosis, identify areas of stenosis or occlusion, and evaluate integrity of vessels in trauma setting. Now, scanning techniques and choices. So, regardless of the type of examination, the following guidelines help ensure meaningful images. So, select the name and the ID of the patient appropriately. That's the first thing. Then you select the proper transducer, whether you're using a convex, a linear probe, or phase array probe, etc. So it is critical for a successful scan. Then the next thing is you determine the frequency, choose frequency. Use the highest frequency that will let you penetrate your target structure. Now the beam should be as perpendicular as possible to the structure being imaged, except in Doppler where you need an angle. Then you go ahead to adjust the TGC and overall gain appropriately. You adjust the focus appropriately also. Optimize the image according to the field of view. Then you scan through the best acoustic window. Like acoustic windows examples are liver, fluid-filled bladder, or stomach. Then you go ahead to get an it's advisable rather to demonstrate long axis and short axis. In fact, making a habit of demonstrating the long axis and turn 90 degrees and demonstrate short axis is very key. Use appropriate breathing techniques, appropriate pressure where necessary. So there is also the Valsalva maneuver. You ask your patient to breathe in and breathe out where necessary. Why? Because you're trying to get the best possible image vis-a-vis quality. Never carelessly photograph an image that is suspicious as for pathology, where you think it is an artifact. So you have to pay attention to details to differentiate what you're actually photographing. Level your image appropriately using the scan plane, the side of the scanning plane, and then the organ name. Avoid writing over images or organ. So label your image appropriately using scanning plane, the side of the scanning plane, and then the organ name. So avoid writing over images or the organ. Then you go ahead to read the anatomy, artifacts, and pathology if there is any, using appropriate image orientation. Then complete your scanning in a coordinated manner within specified time for particular examination. So you have to be coordinated. So if you're starting with the liver, start with the liver. Then you go to the gallbladder. Then you go ahead to the stomach. Then you go ahead to the spleen. Then you go ahead to the left renal organ. Then come through to the right renal organ, bowels. Be coordinated. Don't jump from the liver to uterus, from uterus to kidneys, from kidneys jump to the heart. Then you don't scan that way. Be coordinated. And a quick one, also write your report according to how you did the scan. It will help you a great deal. Now, the American Institute of Ultrasound in Medicine, that is the AIUM, has established the standards for sectional views, annotations, or labeling, and patterns of image orientation for ultrasound images, so that the sonogram done anywhere can be interpreted in a similar fashion with no misunderstanding. Now, let's look at the sectional views and how we can label them accordingly. Ultrasound image can be taken in different body planes called scanning planes, and also in different approach. Example, sagittal or longitudinal scan plane can be obtained using either anterior or posterior approach. Transverse scan plane, or what you call axial, can be obtained using anterior, posterior, or lateral approach. The coronal scan plane can be obtained using a lateral approach with either sagittal or transverse plane. And the scanning planes used in sonography are the same as anatomical plane. The basic principle of examining everything in ultrasound imaging is in at least two planes. In this way, one can avoid missing small lesions or misinterpreting artifacts as ray alterations. You scan in two planes so that you can tell for sure whether that is an artifact that you are looking at, or the artifact goes away when you move to another plane. It's very important, and don't be in a hurry. Now, labeling. All ultrasound images must be labeled appropriately so that you can understand or identify the image scanning plane, the location and the organ correctly. It is essential to recognize the structure and or anatomical or the anatomy accurately, including the relationship of that anatomy with the surrounding structures. How do they relate? Besides, labeling is important because it has medical, legal implications. One should write the labeling over the structures in the sense that you do not label over it and obscure the structure you are labeling. So they must be in a blank area at a corner of the image, preferably in the left upper corner. The common abbreviations can be used in writing labeling. So according to the AIUM protocol, order of labeling is as follows. You identify your scanning plane, you identify the body position you are scanning, and the name of the organ. That is how you label. For example, sagittal right kidney. So sagittal is the scanning plane, location in the body is the right side of the body, the organ is kidney. So another example is sagittal left spleen. So sagittal is the plane, the scanning plane, left is the side of the body, spleen is the organ. You can also do that for transverse midline aorta. Transverse scanning plane, midline position of the body, aorta is the structure you are interested in. The sagittal right prone kidney. Sagittal is the scanning plane, right is the position of the body, prone is the placement of your patient. Usually we scan on supine position, but where you are scanning on a prone position, you indicate that this kidney I'm looking at, this organ I'm looking at, was taken on a prone position. Very important, and that is how to label. Image orientation. Now, let's look at the indicator to screen orientation. So, every transistor has an indicator or a marker, and it's important to know how this indicator is orientated relative to the screen or the TV monitor, and how the probe and the indicator are placed and oriented relative to the patient. There are two types of indicator to screen orientation in standard ultrasound imaging. The top of the screen is closer to the probe. The bottom of the screen shows structures farther away from the probe. The left side of the screen, as it's viewed, corresponds to the side of the probe marked with an indicator. So most probes actually comes with a marker. So you should be able to identify what is the marker. Not every notch or impression on the probe is the marker, but please identify which one is the marker, because some of those notches are for needle placement and stuff. The indicator on the transducer may differ widely between manufacturers, and it's typically a bump or a groove. So you look at your probe, on the surface of the probe, on the either side, check whether you're seeing a bump or a groove. But remember, I said it's not every notch or groove that is the marker. You should be able to identify it. So it's important to verify your orientation prior to beginning any ultrasound scan. Make it a habit to look at your probe to see where your marker is. Now this should be done by placing a small amount, just in case you don't know which is the marker or which side of the probe corresponds with the patient body and the screen. All you need to do, you place a small amount of gel on the side of the probe where you believe the indicator to be, and confirm that that side with the gel corresponds with the side of the screen as it is viewed. Yeah. So if you place the gel, a little pinch of gel on your probe, on the left side of the probe, it should correspond with the left side of the screen on your display, and vice versa. So where you have been able to do that successfully, now you know the orientation of the probe to the display. Now this image will show you what I just talked about. So you see a pinch of gel is placed on the corner of the probe, and the impression is made on the field of view just in the same corner. So it's placed on the left, the impression is made on the left side of the field of view. Now what about indication to patient orientation? Now once the indicator to screen orientation is understood and verified, the probe is then placed on the patient and the image are viewed on the screen. Now the top of the screen will show structures closer to where the probe is placed, with the bottom of the screen showing structures farther away from the probe face. Yeah, the left of the screen will show structures towards where the indicator is directed. That's the left of the screen. Another way to think about this is to think of holding the probe in a different ultrasound scanning plane, such as sagittal, transverse, coronal, or oblique planes. Now, the scanning planes used in sonography are, like I said before, the same with the anatomical body planes, but their interpretation will depend on the location of the transducer and its indicator on the body surface. It depends on the sound wave approach from from where the sound wave entered the body, whether it's from anterior or posterior, etc. Now, sagittal plane, in this case, two sound waves approaches are possible in sagittal plane for abdominal scanning. You have the anterior in supine position, posterior in prone position. Now, sagittal plane anterior approach, the transducer is placed anteriorly in a supine position on the skin surface with indicator of the probe cranially towards the head of the patient, like you see in this image. Now, the left hand side labeled cranial is towards the head of the patient. The right hand side labeled caudal is towards the leg of the patient. Then the topmost part, you see your probe placed on the patient. That is the surface of the patient abdomen. Then the posterior is actually structures that are behind the patient. Now, because you're trying to make a slice through the patient, so what you see in the field of view according to how the organs appear on the slice. Then this image also shows the same thing with respect to kidney and the liver, and the other image on the left shows what happens when you scan midline, where the transducer is placed anteriorly near the pelvis. So you see the bladder, uterus, and all the structures posterior to that. Now, sagittal plane posterior approach, the transducer is placed posteriorly in prone position on the skin surface with the marker or the indicator of the probe cranial or towards the head of the of the patient. Like you see here, this is a prone position for the patient. So you see the posterior, remember it's prone, so you're going to be placing your probe on the back of the patient. So that's posterior, which is at the top, then anterior, which is at the bottom of your field of view. Then of course the cranial and the caudal remains the same. So that applies to these images on the prone position. Transverse scanning plane. Two sound wave approach are also possible in transverse scanning plane. You have the anterior in supine position and the posterior in prone position. Now, transverse scanning plane in anterior approach, the transducer is placed anteriorly in supine position on the skin surface with the marker or the indicator towards the right of the patient. So you can see the image in transverse midline in this case. The right marker is towards the right, the left is towards the left, and posterior shows every other structure that is distal to the probe. Now this image also shows the same thing for transverse on the right hand side, showing the liver, kidney and other structures that apply to that, but again on the transverse view. Transverse left still for kidney and other structures. So this to help you understand that every structure, every organ can be scanned in two planes, and that is something you should make a habit to practice. Now the coronal scanning plane for abdomen, two sound wave approach are possible in coronal abdominal scan. The left lateral decubitus, that is, you can have sagittal and transverse. You have the right lateral decubitus, sagittal and transverse. You have coronal, left lateral decubitus, sagittal or longitudinal. Transducer is placed on the left lateral decubitus position on the skin with marker or indicator of the probe towards the head of the patient. Like you have in this case, you have the coronal sagittal on the left hand side. So you can see the spleen, the kidney in the field of view. So the cranial part is on your right, the caudal part is on your left side of the screen. Then the media is actually appearing posterior because you are looking at it at coronal plane. What about orientation in endovaginal or transvaginal scanning? Two sound waves approach are possible when doing transvaginal scanning. The sagittal and transverse. The transverse in this case is the coronal view. Now the sagittal or the longitudinal transverse approach you see in this image, you can see the drawing vis-a-vis the scan image and how it appears. Then you have the coronal view for the drawing and the scan. So basically you rotate your probe 90 degrees always, 90 degrees, not more than 90 degrees. But again, it depends on the plane or the approach with which you are coming. So orientation of image in scanning infant brain, the same thing. Two sound wave approach are possible when sound beam passes through the anterior frontal of infant brain during neuro sonology scanning. Sagittal midline, sagittal right and sagittal left, all for the sagittal plane. Coronal plane, you have a coronal frontal, coronal mid, coronal occipital, all for coronal plane, scanning plane. Sagittal approach through the anterior fontanelle in infant would appear this way. So this is a sagittal midline approach for corpus callosum. You see the third and fourth ventricle, massa intermedia, cerebellum, cisterna magna or posterior fossa level. can see that. And on the left side of your screen, you see the sagittal left approach and you see left lateral ventricle, caudate nucleus, and thalamic level. The coronal approach through the anterior fontanelle of infant brain, you see the image, coronal approach. You have corona and mid anterior plane where you see those structure, and the coronal approach for occipital or posterior plane. Now, image recording. All exams must be well documented and recorded. It is very important that the patient name, patient identification number, date of examination, and proper labeling must be included in all your images. There are various methods of recording, such as digital store images in the machine, or you have PACS, patient archiving and communication system. You can also store in CDs, DVDs, or you can store in hard copy prints by thermal printer, PC printer, or in imaging film by multi-format camera. Now, patient preparation for every scan. Patient preparation varies with parts that you want to scan, and this will discuss in perspective as we discuss various ultrasound of various organs and issues. Usually, patient will be should be fasting for at least 6 to 8 hours before an upper abdominal examination. For lower abdominal or pelvic examination, patients should take like 2 to 30 O's of plain water at least 2 hours or 1 hour 30 minutes before they come, so that their bladder will be adequately full. Now, that measurement of water is dependent on your location, dependent on the measure of water in your location. For some places, it just take 2 cups of water, some 1 bottle of water, depends. But just know what works for you. But the most important thing is to have the patient bladder adequately filled, not overfilled, so that it doesn't distort your anatomy, but adequately filled for better interpretation of image. Now, let's look at some technical points. Errors during scanning are commonly done due to these reasons. Technical proficiency of the examiner, and the reason why you must have me to eliminate that problem. Yeah, that's why I'm here. That's why I'm in front of your screen, teaching you so that you can have a better technical proficiency. Number 2, patient preparation and or proper positioning, breathing techniques and all that. Things you need to know. Transducer and frequency selection. You must know how to select your transducer and select your frequency adequately. Adjustment of control, number 3. You must know how to adjust your control. There is the gain, there is the TGC, there is the far near gain, there, and depth, focal zone. These are controls that you must master to be able to optimize your image. Technical points to number 5. Incorrect use of Doppler. I'm sure in lectures to come you learn what to do at what point. Number 6, failure to recognize artifacts that may mimic pathology. So, like I said earlier, that's why you have me to teach you. But go back to all our previous lectures. We've talked about artifacts, and you learn a lot from there. The next point is incorrect measurement of structures and organs. So these are the technical points you should look into, and follow my lectures, and you see how we deal with these issues one after the other. Now, patient sonology interaction, very important. So are you supposed to speak to your patient? Is your patient supposed to talk to you? These are issues we need to look at. Patient should be a top priority in every scan. So talking with your patient will relieve patient's anxiety. And it will provide you a flood of information which will give you clue to what you should be looking for with greater emphasis. The info provided by referring physicians are usually limited, so you need your patient to give you more information with respect to that, so that it becomes useful for your work, and it will help you greatly to reach the diagnosis. So please learn to speak to your, but don't overstretch your discussion. Keep it professional and keep it within the limit of time and requests. How to write an ultrasound finding or the technical impression and differential diagnosis. Now, the technical impression or ultrasound finding is the information in writing format regarding the study that the sonographer provides for the referring doctor. So let's look at it step by step. Step 1. As you look at the image, you should first decide whether the lesion is representing a normal anatomy or an artifact or an abnormality. Abnormality will mean pathology or variation in anatomy. Then step 2, if it is more likely to be an artifact, try to eliminate it and then rethink about the nature of the still persisting abnormal lesion, and now decide if the lesion is a focal lesion, and if so, is it a cyst, is it solid, is it complex? Now, if it's a cyst, is it simple or complex cyst, with or without septations? Is there debris? Is there internal echo? If it's solid, is it homogeneous? Is it well defined? Is it isoechoic, hypoechoic, or hyperechoic? Is it heterogeneous with ill-defined margins or mixed echogenicity? Now, if it is complex, is it complex with predominantly cystic? Is it predominantly cystic or predominantly solid? Then step 3. Describe the lesion by using the terminology criteria listed from what we just talked about in step 2. For example, for a cyst, is it a cyst, solid, or complex lesion? For example, the shape. Rounded, is it rounded? Is it oval or spherical, etc. Then with respect to the margin, is it well defined? Is it ill defined? Is it regular? Is it irregular? And so on. With respect to the wall, is it a thin wall? Is it smooth? Is it thin and smooth? Is it thick? Is it irregular? And so on. Now look at the structure and describe the internal echo texture. Is it homogeneous? Even? Is it even? Is it uniform? Is it fine? Is it heterogeneous? Is it mixed? Or is it coarse? Etc. These are the things you look at. With respect to echogenicity, is it isoechoic? Is it echogenic? Is it hypoechoic? Is it anechoic? Is it echo-poor? Is it sonodense? Etc. Now look for calcification. Now with respect to calcification, you determine whether it's micro or macro calcification, or eggshell calcification, and so on. Look for any peripheral halo, if there is any. Look for any useful artifact in or around the lesion and describe it. For example, posterior acoustic enhancement, posterior acoustic shadow, comet tail, and so on. Look for any increase or abnormal vascularity within the lesion or around the periphery of the lesion. Step 4. Determine the exact location of the lesion or abnormality. Which organ is involved? On which side? Is it right or left? Try to pinpoint the location by using the anatomical relation of the surrounding structure and landmarks. Step 5. Measure the size of the abnormality if you find an abnormality and document it in at least 2 planes. Remember, you must always scan in 2 planes. Step 6. State the differential diagnosis by using any relating issues. There is a surgical history, you know the clinical history, you know the present, past history, clinical presentation, drug history, other lab data like a lab report, whether it is X-ray, CT scan, MRI, or previous ultrasound even done, and ultrasound finding you have described above. Step 7, your final diagnosis. If possible, write the final diagnosis by using all the above information. In patients with critical history, ultrasound appearance alone may represent a number of different abnormalities. So you may want to pay close attention, know which is which and what applies to what. So when you do all this, you can pull all this information together to come at a relatively conclusive diagnosis. But again, remember, put your differential diagnosis. It gives an ample or a buoyant arena for the physician to decide on the patient's case. And I want to thank you for attending this lecture. Please like, share, subscribe, and put on your notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019 144 175. Or visit our online store at sonoeyes.business.site. Attempt the quiz in the description and leave me a comment. Until the next time when I come your way again, keep learning ultrasound.